about the causes, the most common causes, like your peanuts, your seafood, red meat, and the other types of food as well. Then things that are not food, these are food allergies, right? And then there are a lot of them. Then there's grass, there's pollen, things like that. There's medication and etc. Ne? So, and we did say that the first time a person is exposed to an antigen, there are antigens that are disease causing. There are antigens that are disease causing. These antigens are disease causing. And those disease causing antigens are called pathogens. If an antigen is disease causing, then the body has got a right to trigger or to initiate an inflammatory response. In the form of release of mediators, that kind of a thing, your cytokines, all that kind of a thing. So, and we said that your disease causing antigens are called pathogens, and those are bacteria, viruses, fungi, and the likes, right? But now you've got antigens that are not pathological. They are still antigens, but they are not pathological. And these non-pathological antigens are these things here. They are not, peanuts are not disease causing, seafood not disease causing, grass not, pollen, medications like penicillin, those are not disease causing. But for some reason, the body still initiates an inflammatory response to them, right? So when that happens, the body sort of makes these allergens. It's the body that decides. I mean, like I said yesterday, that when someone who's allergic to peanuts, they eat peanuts, their body initiates an inflammatory response and releases inflammatory mediators and all those things. That's for someone whom their body sees peanuts as an allergen. But someone who does not have allergy to peanuts, for instance, when they eat peanuts, their body does not initiate an inflammatory response, and therefore there is no inflammatory mediators that are being released there. That's where the difference is. So we said the body has got every right to initiate inflammatory response, to produce and release inflammatory mediators if the antigen that has entered the body is disease causing, like you said, a pathogen. The body is very correct to do this. But now the problem is that the body initiates an inflammatory response and releases chemical mediators even from things that are not pathological and makes them to be allergens, right? So we did say that the first time you eat whatever, let's say you get contact with whatever of these, let's say you eat the peanut, like I said, the first time you eat the peanut, you will eat the peanut and then the body is gonna make the B cells are gonna make antibodies This is where the body gets it gets it wrong. If a peanut is not disease causing. It's not a pathogen. So the B cells are not supposed to be producing any antibodies there. It's not supposed to be happening, but in this case it happens. So those antibodies, they go and attach to the mast cells, like I said yesterday, to the mast cells and the basophils, which are white blood cells. This is the first time it happens. This is called sensitization, like I said. Sensitization. Now, that's why a person would get an injection of penicillin, whatever parental penicillin they get, they don't have a problem now. Then the next time they get it, they get into anaphylaxis. The second time they get it, they get into anaphylaxis. And then people are like, but you got it first time, what happened this time? It's because the first time they're just being sensitized. So there was no inflammatory mediators that were released at this time. It was just the production of antibodies only, right? I'm going to repeat this. I'm allergic to peanut butter, but I don't know. So what happens is that I take the peanut. The protein in the peanut butter causes the B cells. The B cells recognizes the protein in the peanut butter as foreign, as a pathogen, but it's not. And then because of that, they produce antibodies against that protein in the peanut. And then those antibodies, they go and attach to the mast cells. Then they just sit there. Then now, that's the first time. Then the second time this person takes the peanut butter, that protein go now and attach there. And there's antibodies there. And that causes, these are the mast cells, like I said, the mast cells. Now, these mast cells, when that happens, when an allergen attacks to them, and then there's a combination of the allergen, the peanut protein, attaches now to the antibodies. This causes a massive release of inflammatory mediators. And the major one here is histamine. Yes, there's other cytokines, leukotrienes, and all those things, but histamine is the main. So now we're going to talk about the effects of the histamine. So you've got million mast cells, and then this is happening in all those million mast cells. Then they start degranulating, and they release huge amounts of histamine and other inflammatory mediators. So now you have floods of histamine in the body now. You've got floods of leukotriene, tryptase, leukotriene. And then now these, remember, histamine has got about 4 receptors: H1, H2, H3, H4. Now this histamine goes and binds in all the cells that are in the body that has got receptors, and histamine receptors are very abundant, are found in almost all body tissues. Now those histamine so the histamine goes and binds to the receptors in all the parts of the body. In the bronchial tree, histamine goes and binds to its receptors, and then that causes bronchoconstriction of the. So there's contraction of the smooth muscles. There's contraction of the smooth muscles. So there's contraction of smooth muscles. This causes bronchoconstriction. This causes bronchoconstriction. And then clinically, the patient will be in respiratory distress. They'll have wheezes. Right? That's the lungs, the bronchial tree. That same histamine goes to the skin. The receptors, so the mast cells that are in the skin, when they release their histamine, it causes in the skin, the cutaneous manifestation would be things like your hives. There will be itching. There will be erythema. There will be, there will just be rash. There will be swelling. That's the skin, and other features as well. So this is the cutaneous manifestations. This is the respiratory. The issue is the issue with anaphylaxis is that, like we said, it's multi-systemic. This is one system, this is another system. When you've got an allergic reaction that is localized to one body part, like just in the skin, you are unlikely to get into anaphylaxis. Like I said, contact dermatitis. So those are your milder forms of allergic reactions. So, and then you've got CVS. This is where, well, this is one of the big problems with anaphylaxis. Those histamine receptors, when they are being activated, they cause vasodilation. So when you get vasodilation, remember you are decreasing your peripheral resistance. Once you decrease peripheral resistance, you are decreasing your blood pressure. Once you decrease blood pressure, the patient becomes hypotensive. Once you become hypotensive, you get, that's where the shock is basically, anaphylactic shock. Because what happens when you become hypotensive, you get hypoperfusion of your organs. You can even get organ failure. You get hypoperfusion of your vital organs. Yes, you're gonna get reduced cardiac output. You're gonna get, but the major is that massive vasodilation. It's so scary. That's your CVS. What other system is involved? So you can also get your GIT being involved. GIT, gastrointestinal tract. Then the manifestation there would be nausea, vomiting, diarrhea, abdominal cramps, things like that. That would be a GIT. Yeah, under the skin, they might come in with periorbital swelling, swollen lips, something like called angioedema, right? So yeah, so guys, imagine you give a patient an injection, a patient that has been sensitized You give them an injection, and then in less than 2 minutes, they collapse on the floor. What would you do? This is what it's all about. Or imagine you are injecting contrast because the radiologist is not there, only the radiographer is there. You put that contrast and then the patient collapses. Then you check the vitals, hypotensive, starting to wheeze and respiratory distress, things like that. What would you do? So the first thing to think about is anaphylaxis. So now, when it comes to the management and all of that, it's very important to note that the patient is going to just be uncomfortable with the GIT symptoms, but they won't die because of that. Even this one, they'll just be uncomfortable from the cutaneous manifestations, but they won't die from that. But this is the big one. These two, big one. The big one. So, you have a scenario where you suspect anaphylaxis. So what are you going to do? Yes, we're going to do the ABC approach. The ABC. So, for the A, we want to make sure that this person, because when they are collapsed, they might lose consciousness and they might be obstructing their own airway. Their tongue might be obstructing their own airway. So you need to make sure that they are lying in a position that to make sure that their neck is not hyperextended or it's not flexed, it's just in a neutral position. Like the basic things that we normally do, and make sure that we protect the airway. We make sure that the tongue is not falling back if they've lost consciousness, things like that. And also, and make sure that the patient is breathing and things like that. So the interventions that we need to make sure that we master here is that when you cannot, bagging the patient with the ambu bag and call for help will save your patient. Will save a picture, because you don't want to start now focusing on the circulation and other things. You've already seen that there's a problem with the breathing of the patient or the air of the patient already. So you want to make sure that you've got an ambu bag. So because this is admissions, and then you call the other people. While you are maybe managing the airway, you make sure that you get other people to get the drugs, to get the trolley. Someone try to access IV line, because you are going to need fluids. You are going to need 2 IV lines, because you're going to need one for eye fluids and the other to give the drugs that we are going to talk about. So so you want to make sure that wasn't really planning to talk about this in detail, but we need to make sure that the neck is in a neutral position, not flexed, not hyperextended. We need to make sure that we protect the airway, make sure that the positioning of the tongue will not fall back. There are devices that can be used to put into the mouth of the patient. So remember, when we are managing the airway, we also pay attention to the C spine. We don't want to break a patient's C spine. And then in terms of the breathing, after we've made sure that the airway itself is fine, make sure that the patient is breathing. If the patient is not breathing, then you are going to start with your ambu bag and breathe for the patient. That's where you talk about the ambu bag. You bag that patient, and they obviously have called for help and all of that. You make sure that there's air entering those lungs. And then someone is getting 2 lines here. 2 lines. Yes, we're going to talk about how to make sure that the patient is receiving adequate air. If you have connected your sets, you can look at your if you've connected your obviously you are gonna connect your probes there and everything. So listen to with the stethoscope, see the chest rising, things like that. So 2 lines, 1 line for IV fluids and the other for drugs. So let's talk about drugs on part 3 of this. We're already 20 minutes. What are the drugs? But the most important thing here is that once you think that the patient's got an anaphylactic reaction, think about airway, breathing and circulation. And the third thing is that as a doctor, when the nurses call you, they know that they've called a doctor and you need to go there and be the leader in the team because you are the doctor. So you need to know that, okay, I'm gonna do this, I'm gonna tell the other people to do this, because you need to take your roles. Everyone needs to take their own roles. So your role as a doctor, I would suggest that you make sure that you look at the patient's airway, make sure that the patient, the neck, and like I said, is in a neutral position, the tongue is not falling back. Put a device if you have to, because they would have lost consciousness if they've got anaphylactic shock and all those things. So make sure that you stay by the head of the patient, and yes, you're gonna be the one that is begging if you need to beg, and then tell the other people to do the other, connect the monitors, put in IV line, all those things. But if someone, for some reason, you think that the other person is going to struggle with an IV line, after stabilizing that part, you can quickly change roles and say, okay, stay with the A, I'll go and try and help with the IV line. So let's talk about drugs in the next video, guys. But the most important thing is that anticipate anaphylaxis. Anticipate anaphylaxis. Anticipate anaphylaxis. Yeah. Even with the bee sting, if a patient comes in, they have a history that they were attacked by bees, what is gonna kill them is anaphylaxis. They're not gonna die from the stings themselves, but the anaphylaxis. So yeah, let's meet on part 3.